Hi everyone. In this video, I'm going to talk about multi-fetal gestation and malpresentation. So there would be multi-fetal gestation, and that's some typical classification of twin pregnancy. And then we'll have a twin transfusion syndrome, which could be a complication of multi-fetal gestation, and breech presentation. As we said, we're going to do the malpresentation. Okay, so multi-fetal gestation, it could be two, three, or more. So we're talking about the twins, right? And the twins could be either fraternal or identical. Fraternal are the ones in which there is formation of two different zygotes, not just one egg which gets fertilized and then divided into two. It's two different zygotes in the first place. So there are 2/3 chances of having dizygotic or fraternal twins. So majority of the twins are dizygotic 2/3. And then the risk factors of having a dizygotic twin include in vitro fertilization, increased maternal age, newly discontinued OCPs, and ethnicity. So these are some risk factors which could lead to dizygotic twins. Newly discontinued OCPs, for that I believe, as OCPs do suppress ovulation, and now you just have newly discontinued them, so the ovulation is getting back, and instead of one there's two eggs and then two zygotes and then twin pregnancy, right? So this is dizygotic fraternal. And how do you determine the zygosity? You see the number of placentas, you see the thickness of membranes, you see the twins, both of the twins, their sex and their blood type. So that helps you know their zygosity. If they're identical, then it's monozygotic. If they're fraternal, then it goes to dizygotic. Okay, and now we're going to talk about a little bit of their complications. Clinical features includes the complication because they usually present with complications. So just imagine being pregnant with one kid would lead you to puking and all of those complications like anemia and stuff, right? And compressive symptoms, and then might be chances of placenta previa, placenta abruption. Now it's multiple gestation. It's not just one baby, it's more than one babies. So all of these things, all of these complications, chances of having these complications would just increase, right? So here's a table which divides the complications into maternal, fetal, and uteroplacental. So we're going to talk about maternal. Hyperemesis gravidarum means lots and lots of puking, gestational diabetes mellitus, gestational hypertension, anemia, physiological stress on all systems, compressive symptoms because now there are two babies in the uterus or two or more even, and then that would lead to cesarean delivery and thrombosis. So maternal complications. And in fetal, they could be premature, their growth would be restricted, they present one would be vertex and then other would be breech position, and then congenital anomalies, and then twin transfusion syndrome. One becomes the donor and one becomes the recipient, and donor just keeps on giving and become growth restricted, and recipient would become macrosomic, or they would have some congestive heart failure because of too much preload. And then increased perinatal morbidity and mortality just because of these reasons. And then twin interlocking. What if twin A is breech and twin B is vertex, and they get interlocked between each other? So twin interlocking and single fetal demise. So this would be fetal complications. Talking about uteroplacental, then there would be, of course, now placenta is, if it is monochorionic, of course, now the placenta is trying to provide both of the babies, or even more babies. So premature rupture of membrane, there would be insufficiency, right? So it could be even preterm labor, premature rupture of membrane, polyhydramnios, placenta previa. See, now more than one baby needs to get their placenta inserted. So in uterus they don't find enough space to get, and what if they just embed their placenta on the cervical os? So that would be placenta previa, placental abruption, postpartum hemorrhage, uterine atony, umbilical cord prolapse, cord anomalies, filamentous insertion, which is two vessel cord. So these are some complications of multiple gestation. How would you manage them? So first of all, ultrasound would be needed to determine the chorionicity. It must be done within first trimester, ideally 8 to 12 weeks. So around 8 to 12 weeks, you get to know in first trimester the chorionicity. Okay, now chorionicity means number of placenta, right? So if it is monochorionic, then we have if even if it's dichorionic, we just have to increase the antenatal surveillance. We have to closely monitor it now. This pregnancy is to be closely monitored. So if it is monochorionic, even more closely monitored. So every 2 to 3 weeks, starting from 16 weeks, we have to go for serial ultrasound. And but if it is dichorionic and diamniotic and it is uncomplicated, no problem, so we could also stretch it to every 3 to 4 weeks, meaning every month we'll just go for ultrasound. From 18 to 22 weeks of gestational age is the critical time period, just to assess growth, that if both of them are having equal amount of nutrients, no one is just transfusing, and there's no transfusion going on. And yeah, just because we have to assess the growth, so we'll just closely monitor them. And then other than that, Doppler flow studies weekly if discordant fetal growth. So if there's discrepancy more than 30%, one is getting bigger and bigger and one is being smaller and smaller, we have to go for Doppler flow studies. That like, what's the problem going on is that one baby is getting maybe one baby is getting less blood and the other one is getting more. So one baby is being deprived from the nutrients, right? So just like this, if it is this pregnancy, the one placenta is right here and it's going here and here too, so it's being divided in both of the babies. So just like that, we have to be sure if it is going equally on both the sides, right? So we just have to assess that we do by Doppler flow studies. And then biophysical profile too, in which so in biophysical profile was lab, amniotic fluid index, and movement of the baby, and this was breathing, and limb extension and flexion, so tone of the baby. So and with that, we also look at the non-stress test, so 2 score for each and then 10 score. Right, moving forward, we're gonna look how would we deliver the babies. It could be either vaginal, it could be the cesarean, vaginal or cesarean. So we have to look at the amnioticity. I'm not even sure if it's a word, yeah, but if they are monoamniotic, which means that they are in the same amniotic sac. Both of the babies are in the same amniotic sac, right? So if they are monoamniotic, then we cannot go for vaginal delivery. We don't want to have a rupture of membranes and then delivering one baby and the baby B is just waiting behind with the rupture of membrane and just waiting for some infection to get in, right? So if it is monoamniotic, we just have to go for cesarean delivery. All monoamniotic twins need to be delivered by cesarean delivery. But if they are diamniotic, even if they are 2 placentas, dichorionic, or 1 placenta, monochorionic, we can attempt vaginal delivery. If twin A presents as vertex and growth discrepancy is less than 25%, no major changes in their growth. One is not growth restricted and the other one is not macrosomic. So growth discrepancy is less than 25%, and if baby A, who's gonna deliver first, is in vertex position, we can go for a vaginal delivery. Otherwise, we have to go for cesarean delivery. 40 to 50% of all the twin deliveries is cesarean delivery, and 10% of the cases have twin A delivered vaginally and twin B delivered by cesarean delivery. So either just go for cesarean delivery at all, right? Don't go for vaginal. Mode of delivery depends on the fetal weight, gestational age, chorionicity, and presentation of the presenting twin. Okay, so this was about the multi-fetal gestation, and in this the diagram we can just quickly see the classification of twin pregnancies, starting with the top 3, this and this. What we can see is the placenta is 1, which is called as monochorionic, but it has different shapes. This one goes like zoop zoop, which is a forked cord, and this one is just one cord. It's just giving away 2 branches, so it's one cord. And this one has their own cords, and this one is all of these are monoamniotic, monochorionic. We can see they're in one amniotic sac and they have 1 placenta. Got it? Then in the pictures down there, you can see they have 2 sacs, right? Over here that sac is separated, but over here it is fused. And then they have 2 different placentas too. This one has 1 placenta. So 2 different placentas means dichorionic and diamniotic. 2 different placentas, dichorionic. 2 different amniotic sacs, diamniotic. They are separated. They are fused. And this one, 2 different amniotic sacs right here, diamniotic, but 1 placenta, monochorionic. Right? Okay. Which one did we discuss that they should have cesarean delivery for sure? Monochorionics one. Oh, I mean monoamniotic ones. Yeah, I was marking right. So the ones which have 1 sac. Twin B doesn't want to be left alone behind. They want to go out together, or even one by one, but just quickly, right? We cannot risk them because they are in 1 amniotic sac. So cesarean delivery for them. Okay, moving forward, there's one more thing to note here. This time period. So this is the time of cleavage when the zygote was cleaved, right? Divided. So if it was 0 to 72 hours, if it was as early as 0 to 72 hours, both of them got their own chorions and both of them got their own placenta. But if it got delayed 4 to 8 days, they got their own amnions, but they had to have 1 placenta, monochorionic. So they didn't get their placenta each. And if it divided 9 to 12 days, of course, till then, they have 1 placenta and 1 amnion. They tried dividing really late. It was almost like, making a single baby. Single baby was in process, but they just decided at 9 to 12 days that they're gonna just divide and be 2 babies. So they would be sharing both of the chorion and the amnion. But 4 to 8 days cleavage would be sharing placenta, but they might have their own amnions. And if they decide pretty early, if they're decisive enough and they're deciding 0 to 72 hours, like, okay, let's part our ways. So they'll have diamnion, dichorion, each their own amnions and each their own placenta. All right, perfect. Moving forward, I have a little thing in the corner. This must be from UWorld. We determine the zygosity and the chorionicity, the number of chorions, number of placenta in trimester 1. Monochorionic and monoamniotic are least common, but they have highest complication. Just like here, monochorionic and monoamniotic, which we discussed, right? That is why we discussed cesarean delivery for them. So these are the least common because they're so indecisive. They happen at 9 to 12 days. They divide at 9 to 12 days, but they have highest complication rates. So twin to twin transfusion syndrome, cord entanglement, intrauterine fetal demise, most of these happen in these twins, of course, because they don't even have their own amniotic fluid. So they are just dependent on each other, and then one might just die, and then there would be intrauterine fetal demise, and then they would just make some extra anastomosis between each other, and then one would be donor and one would be recipient, which happens in twin to twin transfusion. And then cord entanglement, because both of them have their cords but no different amniotic sacs. So these cords, if there was just one baby and one cord, there would be just there would be a risk of cord entanglement. But now imagine there are 2 cords, so risk would be increased. Monitored inpatient after 28 weeks, and then you can give steroids. and delivery cesarean in preterm 32 to 34 weeks. So we don't really wait for them to get to term. We can just get their the if monochorionic monoamniotic twins, we can just get them delivered if we feel like we can get them delivered preterm at 32 to 34 weeks, but we monitor them inpatient after 28 weeks. We just get them admitted and we monitor them after 28 weeks, and we try giving them steroid earlier too, right? Because they are prone to so much complications. All right, so moving forward, we'd see twin to twin transfusion syndrome. What happens is, I've talked about it earlier too, placental intertwin vascular anastomosis. So the two twins would just make their intertwin placental anastomosis, and they can cause arterial blood flow from the donor to the which passes into the veins of the recipient twin. So 10% of the monochorionic twins do this. So monochorionic, which have the same placenta. We're not talking about two different placentas. Same placental twins would do this. They will have anastomosis. And concern if more than 30% discordance in the estimated fetal weight. Of course, if they have the change, the discrepancy is more than 30%, then we get concerned. Okay, one is really growing bigger and one is really growing smaller, getting smaller and smaller. So what happens to the donor twin? They'll have growth restriction, hypovolemia, hypotension, anemia, oligohydramnios. And the recipient twin, they will just be taking more and more blood, hypervolemia, hypertension, congestive heart failure, polycythemia, edema, polyhydramnios, kernick tears in neonatal period. How do you detect it? You detect it by ultrasound screening. That is why we're gonna do their ultrasounds more and more often. Right here, monochorionic every 2 to 3 weeks after 16 weeks of gestation. So monochorionic would be closely observed. And then Doppler flow analysis also. How do we manage them? We just go fetoscopically, laser ablation of the placental vascular anastomosis, and this should be done in the second trimester, within the second trimester, 16 to 26 weeks. And then for both of the babies, for the one which was recipient, which had polyhydramnios, we can just serial amniocentesis, we could just decompress it, just take out the fluid and reduce the pressure in the cavity and on the placenta, and try reducing the uteroplacental insufficiency chances. And then for the donor one, who was getting growth restriction, we can give intrauterine blood transfusion if necessary. So this is the twin to twin transfusion syndrome, and it is 10% of monochorionic. Don't forget, it is in monochorionic twins, the ones who share placenta. The ones who don't even share placenta, how can they make anastomosis, right? I mean, not sure, but in monochorionic, of course they would. Like, there's no question. Okay, breech presentation. So here comes the malpresentation. Breech presentation is the one in which fetal buttocks or lower extremity is the presenting part. We determine this on ultrasound. So buttocks or lower extremities present first. So these are the three types of breech presentation. They could be the complete breech, in which there would be hips flexed and knees flexed, and lower extremities are also flexed. So this is complete breech. But frank breech is 60%, and it is the most common one, and this is the one in which most vaginal deliveries can also be possible. But we can also do them in complete breech, but not in incomplete breech, in which one of the footling would be extended, or you just expect one or more of the lower limbs would be below the umbilicus. They wouldn't be flexed, they would be extended. So it would be hard, and it would cause complications if we try delivering them vaginally. But most common breech presentation is the frank presentation, in which we can think of delivering vaginally. So what is the criteria of and also incomplete is also called as footling breech or kneeling breech. So footling breech or kneeling breech. Okay, so what is the criteria for vaginal breech delivery? Frank or complete breech, more than 36 weeks gestational age. So it could be frank, this one, completely flexed, or complete breech, and more than 36 weeks of gestational age. And estimated fetal weight should be around 2.5 to 3.6 kilograms and 5.5 to 8.5 pounds. So this ultrasound assessment would lead to estimated fetal weight, which shouldn't be too much, right? And then fetal head should be flexed. Hyperextended fetal head would would be a contraindication for vaginal delivery. And then we'll continuously monitor the fetus and two experienced obstetrician assistants and anesthetists present, ability to perform emergency c-section. So we are trying vaginal delivery, but there should be an option if we need to go for emergency c-section within 30 minutes if required, and mother is motivated for vaginal delivery, then we're gonna try for it. And in epidemiology, there was an interesting thing that 25% at less than 28 weeks gestation present with breech presentation, but at term it's just 3 to 4%. So what happens to the rest of the 21 to 22%? So what happens is they present it at less than 28 weeks, meaning in the second trimester they do present, but by term in the third trimester their presentation becomes all right, they become vertex. So it is like that, they tend to move and they tend to get back to the vertex in trimester third, right? Okay, risk factors: maternal, pelvis contracted, uterus problems, grand multiparity, tumors, and placental. Maybe there's placenta previa. That's why they have to be in breech position so that umbilical cord is closest to the placenta. And then prematurity, amniotic fluid, multiple gestation, congenital anomalies, abnormalities in fetal tone and movement, aneuploidy, hydrocephalus, and encephaly. So these are some risk factors causing the breech malpresentation. How would you manage them? So we would be needing a pre or early labor ultrasound so that we assess that what's the breech position going on, what's the breech presentation, how is the fetal growth, estimated fetal weight, and placental position, and attitude of the fetal head. We need them flex, we don't want them hyperextended. So we're just going to look for this. For that we have to assess pre or early labor ultrasound. But if we do not have ultrasound, if it's not available, we just go for a cesarean delivery. We'll recommend cesarean delivery, but because we don't know what's going on inside, right? External Catholic version and elective cesarean delivery should be presented as options with the risk and benefits outlined. We will offer them about the external Catholic version and elective cesarean delivery, that you can also go electively for cesarean delivery, because if we are going to go for emergent cesarean delivery after the trial of vaginal delivery, there would be chances of increased complications. So we can offer them elective cesarean delivery also, and external Catholic version. What happens in external Catholic version? We're just performing a maneuver in which we'll just put external pressure on the uterus, and we'll try to encourage to move a non-vertex fetus to a vertex presentation. And non-vertex is not only breech, it could be breech, transverse, or oblique. Okay. Overall success rate and changing that is 40 to 60%. Remember, we're going to do that after 36 weeks because they usually tend to move around on their own. But even if after 36 weeks they're still breech, then we can try ECV. But there are some prerequisites. We need that the baby should be just singleton. We cannot do it in multi-fetal gestation. We need that the baby is unengaged. What if the baby is at station +1, the buttock is at station +1? No, we will not do it. So we want the baby unengaged, non-stress test is reactive, the membranes are intact, and baby singleton. So after 36 weeks of gestational age, we can try ECV. So it's single baby, unengaged, NST is reactive, means baby's heart rate we are closely monitoring is normal, and the membranes are intact. There are some contraindications. So the absolute contraindications, just directly where you cannot go for cesarean delivery, you cannot go for ECV, like placenta previa, previous classical cesarean delivery, you cannot go for cesarean delivery again, right? Why? Because there are chances of rupture, right? Placenta previa, because there are chances of vaginal bleeding, profuse vaginal bleeding. We do not want to move around the baby in such cases. If there's previous myomectomy, it could be weak at that point, and then moving around, it could cause uterine rupture. Premature rupture of membranes, uteroplacental insufficiency, non-reactive NST, multiple gestation, you cannot go for it. And then there are some relative contraindications too, like mild or moderate oligohydramnios. We are suspecting growth restriction, hypertension. There's recurrent previous third trimester bleeding, or nuchal cord, that the umbilical cord is wrapped around the neck. What are the risks? we're trying to put external pressure on the uterus and try to move the baby. Placental abruption, placenta just separated prematurely. Cord compression, cord accident, rupture of membrane, maybe labor gets induced, fetal bradycardia, we need the cesarean delivery as soon as possible, alloimmunization, fetal death, 1 in 5,000 fetal death. So what are the methods? How do you do it? So what we do is we do tokometry and we continuously monitor fetal heart rate, and we try moving them, transabdominal manipulation, ultrasound guided. So we manipulate the fetus ultrasound guided. So we're looking at the fetus too, that what's going on, where's the cord, where are we rolling the fetus. But there's one important thing: if the mothers are Rh negative, after the procedure you have to give ROGAM. Where is the better prognosis? Which patients can expect good prognosis after it? The ones who are multiparous, it's not their first baby. They have good fluid volume, not too much, not too less. Good fluid volume. Their baby is small. They are skilled. The obstetricians are skilled, and the placenta is posteriorly attached, not anteriorly, but posteriorly attached. That would be a good prognosis. But even if it's unsuccessful, just go for planned vaginal breech or planned cesarean delivery. All right, now we're going to talk about vaginal delivery, vaginal breech delivery. It can be spontaneous or it can be assisted. We just encourage maternal pushing. Assistant just applies suprapubic pressure to flex and engage the fetal head. Delivery can be spontaneous. We just have to avoid fetal traction. We don't want pulling in vaginal breech delivery. We can only apply fetal manipulation. We can only apply a little bit of suprapubic pressure if we see that there was spontaneous delivery up to the level of umbilicus of the baby. So up to the level of umbilicus, if the baby is out till here spontaneously, so then we'll try to do some manipulation, because now okay, it's halfway there, so now the baby would come out, but we're not gonna just force and put traction if the baby is completely inside, right? So fetal manipulation only after spontaneous delivery till the level of umbilicus. What are the contraindications? When can we not go for vaginal breech delivery? If the cord is presenting first, or the footling breech, or the kneeling breech, which is called as incomplete breech. And then fetal factors which are incompatible with delivery, like hydrocephalus, macrosomia, IUGR, inadequate maternal pelvis. So these are general contraindications, not specific to breech. And when do we recommend cesarean delivery? So we recommend them cesarean delivery when in labor, if in during the second stage of labor there has been 2 hours passed and there was no active pushing, but there has been 2 hours that the breech has not yet descended in the perineum, right? Then we can go for cesarean delivery. And what if there was pushing? So after pushing, if after 1 hour of active pushing, if vaginal delivery is not imminent after 1 hour of active pushing, if the breech has not descended in the perineum, even after 1 hour, then we'll say, okay, we tried for vaginal breech delivery, now let's go for cesarean delivery. Prognosis, regardless of the route of delivery, even if we are delivering them by cesarean section, breech infants do have lower birth weights. They do have higher rates of perinatal mortality, congenital anomalies, abruption, early premature separation of placenta, and cord prolapse. So perinatal mortality, congenital anomalies, cord prolapse, abruption, and lower birth weights. Regardless of however we deliver them, breech presentations do have these complications. So that's all for this little topic. Thank you.